Jeff, why don't you walk me through? I want to hear how you guys do it in your clinic. Let's take it step by step. When somebody comes in for an adjustment, what's the process like working that patient through the clinic?
So, that patient will come in, they'll get called back by one of our technicians, and then that technician will do the initial workup, usually includes an auto refraction, maybe an aura, so that we can get a general idea for pressure. I don't like to touch the surface any more than I need to on these days, especially to just kind of optimize that refraction and then get the best data for the adjustment if I'm going to do one. This is again typically happening around week 3, week 4, once Dr. Singh or his partner, Dr. Sanka, have done the first YAG capsulotomy on the patient. And then they'll bring them back in, and I'll review the data, make sure everything is making sense. But my technicians are technically checking the eyes monocularly in a well lit environment. I'm seeing what their auto refraction is looking like. I will do the refraction myself. There's typically, and that's done also in a brightly lit room. I will be looking at the patient anterior segment at least heavily, unless something doesn't make sense, and then I'll obviously divert the process and go looking in the back of the eye, do a dilated exam if I absolutely need to. But we're typically just focusing on refraction and anterior segment. I'll take a look at the ocular surface heavily, making sure that my numbers aren't influenced by things like dry eye there. And if everything's making sense, then I will, decide what my targets are for those patients. Typically in the beginning, I kind of have just a standard philosophy where I'll use their dominant eye for their distance. And we've determined that, already with preoperative testing before the cataract surgery was actually done. And then I'll use the non-dominant eye for the near vision eye. I'm usually targeting plano on the distance eye and then -75 on the near eye. I give the patient, a whole heads up. Here's what the light adjustable lens is, just kind of a refresher. Here's what our goals are. Here's what I'm trying to do with your range of vision. Here's my expectations for after the first adjustment. You'll probably tell me your distance vision is good. You'll likely tell me your near vision is improved, and hopefully it's great too. Many of my patients right after adjustment number one is very happy and they have an excellent range of vision. But some of them might need a little bit more optimization after that, and that's what I tell them. I go, you might tell me, alternatively that this is going to be, it's good, but it's not quite where I want it to be, and then we'll have to play with that. We'll have a little discussion about just, how optics works and how I can't break the laws of physics, and there are things that we set expectations at that first one, and that first adjustment, post-op for me is the one where I spend the most of my time, just kind of making sure everything's in order, making sure everything's aligned properly, from an examination standpoint, and then just setting those expectations with that patient so that they know exactly what I'm planning on doing. Now, RxSight just provided us these new, wonderfully printed pamphlets that we can hand out to our patients. So that is now being
Mhm.
incorporated. That's got a lot of data on just what to expect through the entire post-operative process. So now I'm telling them, like, here's this. If anything I'm telling you is going in out in one ear and out the other, you can go back and read this, especially after I've done your first adjustment and you've got a little bit better reading vision there. You'll be able to read through this and get a better expectation of what's going to come, over the coming weeks. And then we'll go from there. We'll usually do the first adjustment. We'll dilate that patient with tropicamide, phenylephrine, cyclopentolate, and then we'll, get them behind the instrument once they're fully ready to go. And then I'll do the adjustment on that patient with the prism and all that. And then we'll see them back the following week and see what kind of feedback they have, how happy they are, and then we'll play with it from there.
The pamphlets that you're talking about, those just came out. We just started using those in our clinic too. They're fantastic. It
Yeah.
does, for lack of a better term, it dumbs it down. It makes it simple, what the patient should expect. We're starting to hand them out at our week one. We do a week one visit always, and it's mainly that visit. I mean, whether it's medically necessary or not, I use it for a data point because I do get a quick auto refract, or we use an aberrometer, just an idea of where the refractive status is. And I use it as an opportunity to educate so they know what to expect. That just keeps things so efficient when they come in for their first treatment. But the pamphlet talks about what to expect. It even has like a little notebook in the back for them to write down concerns or questions that they might have. It
Yeah.
keeps them feeling more involved. So I think that's a really great thing. The first adjustment, what I like to do for my patients, I give them three pieces of homework because 90% of our patients, if not more, are doing some blend. How many of your patients do a blend? Almost all of them?
Yeah, I would say, what I have found with this is that, most people come into this expecting that they're going to have a large range of vision after all this is said and done, and they're going to be able to dramatically reduce their dependence on glasses. I think Dr. Singh and Dr. Sanka, do a good job kind of teeing up the patients for me in terms of expectations initially. But I've also found that, when if there's especially a patient that really wants to push that near vision, they think they want that near vision as much as they say they do, and then they see the little bit of compromise that might happen at distance, and they go, actually, I didn't want this as much as I thought I did. Cut me back a little bit, and I actually do really prefer the distance. So there are patients that do, only distance only, and with the extended depth of focus of those lenses, especially the LEL plus now, they are getting really good near vision, and they are very happy, right off the bat, and may not want much adjustment for the near or any at all. I have had a couple patients that have said, no, I'm actually really good right out of surgery. But typically, yes, I would say most patients, we'll say 90%, anecdotally here, would like that blended, range of vision where they can function at all ranges pretty well.
Yeah, so assuming that's the case, like you said, 90%, that's about where we're at too. Some do want that distance, and that's totally fine. And even especially with the LAL plus, if we set them for plano on both eyes, they're usually functional, at least at computer distance, pretty comfortably. But if we do a little bit of a blend, now the degree of blend is the variable in everybody. I tell them three things. Number one, use your tears all the time, because the light adjustments are going to dry your cornea out. It's a lot of intense UV light, and your eyes are going to feel scratchy, just like if you spend an entire day at the beach. You're going to leave feeling crispy no matter how much sunscreen you put on. So use your tears. Number two, never compare the two eyes, right? You've got two eyes now that are intentionally different. And we want your brain to we want to trick your brain a little bit. Just like I have two hands. I'm a baseball player. My left hand is garbage for most things, but I don't notice that unless you tell me to throw a baseball with my left hand. Right now, sitting here, I can't tell that my hands are different. So when you isolate the two eyes, you're going to notice it. So try not to do that. And then number three, and I think probably most importantly, if we're trying to give you reading ability, don't reach for those reading glasses right away because that's what they always want to do. Reading glasses magnify things. They make things easier. They are called cheaters for a reason. You're cheating the system. Don't cheat. Try to avoid the reading glasses as much as you can. I think that's just such a very basic thing. And patients come back and they're like, I did it, Dr. Bruns, I did it. I didn't use my reading glasses like you told me to. Awesome, cool. And they're like, well, it wasn't good enough. Okay, cool. So let's make it better. And that's where the feedback comes in, and that's where the process. That second visit when they come back on LDD number 2 is my favorite because now you got them. They've seen the magic, they know how it works, and they're kind of involved more than they used to be. They were skeptical before that, but once that change happens, it's just so cool. So you said lights on for the refraction, right? Is
Yeah.
that's pretty
Yeah.
important, I think, right?
Yeah.
Explain
I
why.
mean, that's going to give you better contrast sensitivity ultimately there, and that's going to give you a better, more accurate refraction, I would say. Sometimes, sure, we like to do refractions in lowly lit environments so that we can really see, how the pupil dilates and how we can optimize the refraction. But most people, don't spend a lot of time in poorly lit environments. And when we're dealing with, premium products here and premium implants and premium expectations, we're going to want to simulate the real world as much as possible, and that's going to be in a well lit environment. So, yeah, I typically do everything in brightly lit rooms there.